Hello, I'm Anna Korsgaard Berg. I'm a medical doctor and PhD from Steno Diabetes Center Copenhagen in Denmark, working in the diabetes technology group of clinical research. So I'm really happy to present to you regarding skin problems caused by diabetes devices, a really important issue when initiating insulin palm and glucose sensors, especially in children and adolescents, which will be my primary focus, but it can be extrapolated to adults as well. These are my disclosures. I've received study materials from Decobal for a study, and I also received economical support from both Medtronic, Convatec, and lecture fees from Rubin Medical, because I think it's important to collaborate with the manufacturers of diabetes devices in order to make them pay for part of the solution as well. So as you all know, there's a widespread use of diabetes devices all over the world, especially in children and adolescents with type 1 diabetes. And there are so many benefits from using diabetes devices, insulin pump and glucose sensors, more flexible lifestyle, better glycemic outcomes, etc. Especially when you look into the era of automated insulin delivery, AID systems, this is even more important. But both an insulin pump and glucose sensor needs to be adhered to the skin 24/7, typically with a small patch, as you see in the picture, so that the infusion set for infusing insulin will be kept close, and also so the glucose sensor filament can actually measure the blood glucose in the interstitials. So it looks really nice in this picture, but my experience from the clinical reality is more like this. So these are different reactions caused by diabetes devices. Lipoatrophy, lipohypertrophy, scars, wounds, eczema, and these are especially seen in children and adolescents. So this will be the theme for the rest of my presentation. So this is the agenda. So at first I will say something regarding the types of skin problems, then go further with causes of skin problems, prevention, and then treatment, and at last, but not least, perspectives and recommendations for you. So what types of skin problems do we see? So this is just a short overview of skin problems types due to diabetes devices. So we have primarily 4 types. We have the lipodystrophies, the lipoatrophy, and the lipohypertrophy, primarily caused by the insulin pump and a reaction to the insulin. We have the contact dermatitis, which is the eczema reactions, which is, I think, the major or the worst reaction for many of the children at least, and it's primarily caused by the patches. Then we have the infections, both at the cannular infusion set or center, and then we have the skin injury, which is a group of the rest, skin reaction, typically wounds, scars, etc. And then there's the itching. So itching is a very important symptom that many do complain about, especially if you ask them. And it's an issue that can also interfere with everyday life. In children and adolescents, I have shown that this actually interferes with concentration in school, sleep, other stuff. And there's also can be related to changing the infusion sensor priorly because they actually itched it off. So I'll go through the different types of skin problems. So lipoatrophy is actually a quite rare complication now. It's thought to be some kind of autoimmune response to insulin, but actually we do not know that much about it. The treatment is therefore to change the type of insulin and especially the company, because the preservatives attached to the insulin is sometimes also causing these reactions. This is just to show you how it looks in real life, and this is from an insulin ultrasound measure of it. You can see how it looks superior for the lipoatrophic area, like here. We have the dermis, we have the subcutis, and the muscle shown by ultrasound. And if we look at the lipoatrophic area, we actually see that the subcutis almost disappears. It can be resolved over time, especially in children and adolescents, which are more plastic in their tissue, but but else the last option could be some kind of plastic surgery in order to get lipofilling in the skin again. It's very important to avoid using the area of lipoatrophy because you will then inject insulin into the muscle or have the center in the muscle. Then we have lipohypertrophy. It's a quite frequent reaction to insulin actually. It's a consequence of anabolic effect of insulin. It can be very difficult to see with the eyes or the visual examination, but it's more important to palpate. And the examination includes palpation because then you can actually feel if it's there. It results in hypersensitized areas, meaning that the skin is not that painful anymore, and that's of course leading to the person with diabetes being more prone to actually use that area for the insulin pump for the next set. But it is clearly associated to impaired insulin absorption, meaning that lipohypertrophic areas needs to be avoided. Contact dermatitis is an eczema reaction. It's some kind of inflammatory skin reaction caused by either irritative irritant chemical substance leading to irritative contact dermatitis or an allergen causing allergic contact dermatitis. In order to distinguish between the two types, we need a patch test, which is normally made on a dermatology department, making it important to make a referral to dermatologists. If it's an allergic contact dermatitis, the reaction keeps coming every time you're in contact with that area or with that allergen, meaning that it's for life. Irritated contact dermatitis can be some kind easier preventable in some cases at least. But by now we do not have that much to distinguish between in order to use other device types, meaning that the treatment or the secondary prevention is the same nowadays. I'll come back to that. And then we have the infection. It's not that common anymore. It was mostly described to insulin pump and more frequent 20 years ago. Maybe that's because we have better hygienic procedure or technical design by now, leading to less infections. But when there are infection, these are caused by microbial colonization by Staphylococcus or Streptococcus primarily. But the infection could also be some kind of secondary infection related to either the contact dermatitis or the itching. Then we have the skin injury. So the skin injury is the last group that we identified. It's some kind of unspecific group of reaction due to diabetes devices, primarily patched related. We have the scars and the wounds, which are often related to respectively adhesives or removal. So the scars are some kind of chronic disruption of the skin over time, and is quite frequent in this population. There's the skin stripping or tears as wounds by actually removal of the device can lead to these wounds, as you can also see on this picture, where some of the stratum corneum or skin cells are actually attached to the patch here. So what do you know regarding causes of skin problems? So if I could recommend just one article, I would recommend this. It's a consensus statement actually more than 10 years ago regarding medical adhesives, so patches and plasters, and the need of glue from these devices to the skin. And it's not only related to diabetes devices, but to using adhesive in the healthcare sector at all. And they describe these 4 groups of adhesives. So that's glue actually attaching the device to the skin. There's a latex base, which is primarily not used anymore. We have the acrylate, the silicone, and the hydrocolloid. And what is, to my knowledge at least, most or all diabetes devices are based on acrylate adhesive, where silicone and hydrocolloid are typically more skin friendly, but also have, at least in some compositions, problems with proper adhesion to the full wear time. And of course, it's also a balancing act between proper adhesion and avoid skin irritation, because we need to know that the diabetes device is only functioning, and especially in the AID systems, if they are well attached to the skin. So it's also important that it is proper adhered to the skin, also so we do not need to have extra patches above. But also we need to avoid the skin irritation. So regarding substances and allergens and content, we do know that there are especially the glue from the patch which touches the skin, but also the glue in the housing of the device can actually cause these contact dermatitis, irrespective of type. Some of the most prominent allergens are acrylates and also IPA as one of them, coliformium, etc. But some of the irritative contact dermatitis or also other reactions can also be caused by the occlusion process, the humidity underneath the patch, the tension or pressure. And one of the biggest problems in this is that regarding the allergens, we actually do not know what a diabetes device, what the content of a diabetes device is, because the medical device regulation by now does not say that you have to know which substances are in the devices. So that's of course a clear problem that we do need to have a proper declaration of substances. Also, so we in future at least can avoid some of the substances when we have variable types to change between. If we have a patient or person with diabetes having some kind of allergic contact dermatitis. So it has been also hypothesized that the skin barrier in individuals with type 1 diabetes would be impaired from the beginning, also leading to an increased risk of skin problems to their diabetes devices. And this is just to show you how the skin barrier is compensated by chondrocytes, which are the cell types, and some lipids, and the natural moisturizing factors, or NMF, which actually is very important for the hydration of the skin. And as part of my PhD, I've shown that there are similar skin barrier function in persons with type 1 diabetes compared with healthy controls. And this is just to show you some of all the different things that we actually investigated regarding the skin barrier in children, youth, and adults with type 1 diabetes in a case control study with age and sex matched healthy controls. And this is the box plots showing how all the values are completely similar between cases and controls, except in the adult population of only 9 adults where we saw some differences, but this of course has to be replicated in a bigger study of more than 9 adults. So what do we also know? We also know that there are certain association factors. Only cross-sectional studies of skin problems have been published almost until now, except some few others, but this is just to show you some of the association factors that have been found before. So we have the atopic disposition, we have the duration of device use as the primarily biggest issues. Regarding if age is an important factor, it has been shown in some studies. At least we know that it seems to be more prevalent in children and adolescents, but this can also be caused by a more early implementation of diabetes device in this age group, but also maybe the surface area of a child is smaller than for an adult, meaning that the healing time for each site prior to a new site needs to be used, new device needs to be used there, is of course shorter. Prevention of skin problems. At first, of course, we want to prevent skin problems from arising. And according to Kohl et al., there are these 6 ways of prevent skin problems to medical additives. You have to be aware of the choice of adhesive. Repeated taping has to be avoided, and you have to avoid long-term use of tapes. And these three is not easy to do for us as healthcare professionals in this area. But the last three, skincare, application technique, and removal technique, as important areas, have been implemented in our skincare program, which we have tested in a big study. And I'll just tell you a bit more about that. So it's a cluster-controlled interventional study at 2 sites. We included children and adolescents by initiation of diabetes device and followed them for 12 months. And from the Red Hospital, Herlev Hospital, they received the skincare program, which were a brochure, which is available as a supplement to the article in Diabetes Care. And it said that they should avoid disinfection prior to putting on a new diabetes device. They should use lipid lotion on the skin on the pulse site. So when they have the sensor on the left arm, they should use lipid lotion on the right arm in order to make the skin barrier better prior to wearing a new device there. And then they should be more gentle by removal of diabetes devices. Then control group received usual care. And this is just to show you the basic demographics of this study. So we have more than 100 in the intervention group and around 58 in the control group. So the intervention group were twice as big as the control group, but this was due to a bigger center and not selection bias. So these are the results on eczema wounds and itch during the study and having in the full 12 months period. And as you can see, the blue are the control group and the red are the intervention group. And we saw a slightly lower eczema frequency in the control intervention group compared to the control group. But we saw the biggest difference according to the wounds, where actually we have an odds ratio of 0.3, meaning that 2/3 of the wounds could be prevented by this program. For itching, there were no differences at all. When the prevention of the skincare program doesn't help enough, what can we then do when skin problems arise? So the first is the acute treatment. Of course, most of these skin problems do naturally heal over time, and therefore you have to avoid using the site and change the device site and let it heal before you put on a new device there. Then it can be helpful to use steroid lotion temporarily for up to 4 weeks at the area in order to make it heal more quick. And this is then our secondary prevention stair model. So the first level is skincare and to use more different sites. And by skincare, we mean the skincare program as I described before. Then we have the thin liquid barrier, which is a barrier which can be sprayed on the skin prior to adhesion of a new diabetes device. And the next third step would be use of a patch. We also call it the sandwich method, but it can be quite difficult actually to explain. So we have made some photo guides showed here in order to how to cut out a patch and the device, put it on, etc. So the idea is that you use another patch, primarily with another adhesive that acrylates, so silicone or hydrocolloid, and then make a sandwich between the skin and the device in order to avoid the device adhesive to be in contact with the skin. And the fourth step could be to use preventive steroid spray or lotion, at least punctual, as with atopic dermatitis. But you have to be, of course, aware of the steroid-induced skin atrophy, which is seen if you use steroid every day for 4 weeks. Then you actually get a thinner skin barrier, which have been shown in studies. So what are the perspectives or recommendations based on all this? The major thing to remember from this is that it's very important to look at the skin. I think we as healthcare professionals need to look at the skin and ask to the skin, ask to symptoms, and the family's experiences with this. I think the clinical awareness is very important, but also the acknowledgement of skin problems that they actually can come. And I think it's crucial, as you do here, to actually educate from the beginning in order to avoid most of the skin problems, or at least initiate some preventive techniques from the beginning if skin problems arises. And some recommendations could be to use the skincare program, as we have shown in the diabetes care study regarding skincare, and that is avoidance of disinfections, because it's leading to a more vulnerable skin barrier and more dry skin, which could therefore result in more skin problems. It's to be more gentle with removal of diabetes devices, and last but not least, to use the lipid lotion. But there's a lot of things we do not know regarding skin problems, the relation to insulin absorption, risk factors, and also the glucose accuracy. And I think it's very important to investigate more in the subcutaneous tissue, because that's crucial for the work or the use of AID. And then I think we have to push the manufacturers in order to make more skin-friendly devices, to report skin reactions as a complaint, and also to try to push the governments in order to make better regulation, so we can actually have a full declaration of content. That would also help us in the clinical practice with families where a child have allergic contact dermatitis to coliformia. Then we could maybe find the devices which didn't have coliform in their content. Because I think the overall goal must be that all persons with diabetes should be able to use diabetes devices without skin problems. And on that note, I will end my presentation by acknowledging a lot of important people who have helped me with all this work, both students, collaborators, my PhD supervisors, my whole diabetes technology research group led by Kirsten Nørgaard, and also funding resources which have helped me making all this possible. And these are just some references if you want to read more. And you are very welcome to contact me either on email or on LinkedIn in order to get more advices, or to give me some advices on what works in your setting. Thank you very much, and have a nice day.